Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Daly, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.
Welcome back to the Bone. Today we have Dr. David Kay and Dr. Bryan Hartog. We are talking about Vero Ankle Brace today and what it differentiates from the market and why it's a more superior brace at the end of the day for athletics and general population needs. So, Dr. Kay, do you want to introduce yourself to the crowd and let them know what your background it looks like?
Yeah, so orthopedic surgeon, recently retired, specializing in foot and ankle reconstruction for almost 40 years, taking care of lots of different types of folks during fellowship, really ultra high level pro athletes, to just in practice, just a lot of everyday ordinary people, whether they were involved in athletics, they were hurt on the job, all the requirements that people had. Because been in practice for so long, got to see a lot of the changes that we've done. When we started in practice, it was, oh, you're going to go in a cast for 12 weeks or 16 weeks and just stay put, versus where we're at now, which is, no, we do not want to over immobilize you. We want to get you moving. We want to cut down on all the problems associated with prolonged immobilization. So when we started talking about it, we just saw this massive disconnect in brace management and the rehab side versus what our surgical goals were, and the two have to work in concert. If we do surgery to get people moving and they aren't moved, then that doesn't make any sense. So again, it's a collaborative effort to get people back to their lives again.
Perfect. And Dr. Den Hartog, how about you? What's your background?
So I'm also a retired orthopedic surgeon as of last March, but Dr. Kay and I have been involved with innovation. We both have a desire to make things better. And this kind of started in the late 1990s, where David and I were both in the same medical organization, and we saw each other's desire for making things better. And so we started a company that we saw an unmet need, and then we would try to design plates and screws that would meet that unmet need. But the same thing we saw even after that company sold, there was a lot of other things in our practice that would give pain points to us. And one was we just didn't have a really good brace. There was a lot of cloth type ankle braces with rigid straps, and some were just like sleeves or socks, and some were like almost cast. They were so rigid. So we wanted something in the middle that would give us something that could be worn over the course of a person's injury from the start to the finish through rehabilitation. So we just really felt that we, as surgeons, unlike those other companies that may have braces that were not designed by surgeons, we truly understood the need of the patients, and that's why we developed this Rubber City bracing company to try to meet those needs and bring innovation to an industry that really hasn't had any innovation for over 20 years. So both in material and design.
Yeah, definitely. Well, that's, as an athletic trainer, it depends on what your budget is to be able to tape ankles or buy braces for your athletes, where we're trying to do a lot of prophylactic prevention of ankle injuries in basically basketball and volleyball and football at the end of the day. So trying to find a brace that works for all the athletes has always been a struggle. Every foot's not made the same at the end of the day. Can you guys talk about what makes you guys different and maybe some of the research that's come out about ankle bracing and taping that you guys know of?
So probably one of the biggest things, one of our team members is Dr. Robert Anderson. And Dr. Anderson, I think until recently, was in charge of musculoskeletal for the NFL. And they actually conducted a pretty significant study looking at taping versus bracing, and the conclusions were pretty straightforward. Go to bracing over taping, just because of the expense, the time that was put into it, the fact that taping is good for maybe 10 minutes before it starts to loosen up. And then if you think about athletic trainers, if they have to tape up in even half of a team, that's all they're doing. They're not doing anything else, especially a football team. There's just so many people. And, how do you do this effectively? Plus, a lot of players don't like to be taped. They don't want to be overly constrained. And so it was, that's pretty significant research that to get away from the whole taping idea. Tape is expensive, and tape goes into landfills.
So another thing, Shelby, that study showed from the NFL is that taping, the effect of it to control the foot position, only lasts for about 10 or 15 minutes. And then it really starts to lose its hold on the ankle. So even though it may give the athlete some proprioceptive feel for where their foot is in space, it's not really giving any mechanical support for the foot and ankle. Mm-hmm. So that's why some kind of a material like an elastomer can give, it's waterproof. It actually, you can adjust the tension on it. If it warms up and it expands a little bit, it still doesn't lose its property of a memory material, which basically, and I'm sure trainers know this, it's a memory material is something that is made in a certain shape, but if you distort that shape, it wants to come back to its original state. And that's what the elastomeric is. It's a memory material that pulls the foot back more into neutral, and it maintains that mechanical support throughout the time that they're wearing that brace.
Definitely. So I know we talked about how tape only lasts probably through the warm-up and then it loosens up. With your braces, compared to the competitors, have you guys done any longevity studies for how long it actually lasts? If it's more than a season, with shoes, you get 500 miles and then you have to replace them. Have you guys done any studies on that for your guys' braces on how long before they need to be replaced?
Again, it depends on what sport the athlete is playing. Depends on how much they use it, how much cutting activity occurs. Mm-hmm. Usually in most sports, you do a lot of cutting. But we've not had any issues. We haven't done any prospective randomized, patient-reported outcome studies on this. It's hard to do. When you lose touch with patients, you send them a brace and they may or may not, give you a response. Mm-hmm. But we've had very few braces actually tear at any location. We've had no complaints that it didn't last through a season of sport. I suspect there obviously is, probably more so because of the Velcro straps and so forth around the brace. That's usually what gives first. But that takes several pretty intense activities before that starts to loosen or the elastomeric starts to tear. But again, depends on how big the patient is and how they're using it as to how long it's going to last. But David, you need anecdotal feedback on the patients that you put these on?
Yeah, typically, if we look at a regular person, not necessarily somebody playing sports, they're going to get between 6 to 12 months. And what goes is the Velcro, which is what you'd expect. It's actually pretty durable. Can it be abused? Yes. Can things start to tear? Sure. But with it, because of the material, it tends not to wear the same way that a canvas will. Plus, with sweating, which is a real issue with tape or with cloth braces, it's not going to absorb the sweat. It's a rubbery material, so the sweat's going to roll off of it, and
Yeah.
we're not going to see those same sort of problems. On the design side, one of the most critical elements is how does it fit inside of a shoe? So we purposely left the back open so that we could have the brace and the shoe work together. If you look at most braces, they fill the back with cloth. Well, that cloth changes the fit inside of a shoe, especially if that cloth is really thick and canvasy. So now the shoe isn't going to fit quite right. That's going to bother the player. Um, Nobody's happy about buying new shoes or buying two different size shoes while they're wearing a brace or having their shoes basically destroyed by the brace. People, particularly a lot of athletes are very picky about their shoes. They don't want to be confined to, oh, this is the one shoe that you should wear. And they go, well, look, I like certain shoes because I like certain shoes. So our brace is designed to fit in a variety of shoes. It also makes putting it on a lot easier. You don't have to contort the ankle, especially if it's post-injury or post-surgery, in order to put the brace on. You kind of slide in to the brace. It just makes it simpler to at least do the initial application.
Yeah. Well, and I think with your guys' brace, you guys have a feature that you don't see with every brace is that you can build it up and break it down depending on what stage of post-surgical or post-injury or even just the amount of support prophylactically that an athlete is looking for. Can you talk more about that?
Yeah, if you look at our stirrup is very different from other stirrups. A stirrup is the rigid side piece. Most stirrups are a solid piece of either metal or hard plastic. Well, that doesn't work anatomically. We've got these bony prominences on the inside and outside of our ankle. And if it, we have a cutout. That cutout is very strategically placed, so it doesn't rub on those areas. It's also padded. And we have very simple little mushroom tabs where you can pop one of the stirrups out or both the stirrups out if needed. And a lot of the stirrups are just sewn into the brace and you can't change them and you can't change the position on them. And as the swelling changes, that fit's just going to change a lot. So yeah, we're modular.
Gotcha.
Yeah, we like to call it the continuum of care. I think it's a unique brace in that regard because the way I used it in my practice was if a patient came with an acute ankle sprain, the elastomeric was excellent with a little bit of maybe a sock underneath, then put the elastomeric brace over top and it gives excellent compression. And then you can use it inside of a cam boot as well. The cam boot is very rigid. It's got a rocker bottom to it, so you really can, it does take a lot of stress off the foot and ankle, but the medial, lateral, and anterior posterior compression of a cam boot is real variable. So the patients don't really, they feel somewhat supportive, but they can still see or feel their ankle moving side to side and front to back. And the combination of the two, and most, depends on how swollen the patient is, usually they can get the elastomeric brace with the stirrups and inside of a cam boot as well. As long as you don't, pump up the air pockets in the cam boot, you leave those deflated. But it's amazing how much more stability the patient senses, so they can start to mobilize quicker, and symptomatically and swelling-wise, they're much more down the path of healing. So once the cam boot comes off, say after 2 or 3 weeks after an ankle sprain or even ankle surgery,
Mm-hmm.
If we have a bimalleolar ankle fracture or just a fibula fracture or really a syndesmotic injury, we can start weaning those patients out of the cam boot with just the Vero brace, usually within 3 to 4 weeks. But you first start walking with the inside Vero brace and the cam boot at about 2 weeks when the incisions are healed. And then eventually, again, because of the swelling control, bleeding control, edema, ecchymosis is much less with these braces. They actually rehab more rapidly, and that's where the trainers really can see the difference. That patients actually feel more confident. They start to walk, therefore less muscle atrophy, less bone atrophy, and they're just further along the recovery path back to return to practice. So that's what we've seen in our practices, and the athletes really enjoy that.
Yeah. So, it's a multi-use brace at the end of the day. And, we're primarily working with athletes, but you guys work with the general public also. Obviously, you guys are orthopedic surgeons, but it's medical equipment, post-op, for just general active population, recovery, prophylactic. Can you guys talk a little bit more about the recovery aspects that you guys have seen with the brace also?
Yeah, so one of the most common issues is swelling. So if it's post-injury, post-surgery, there's going to be swelling. And if you talk about how to manage the swelling, which is really critical, um, you can put a compression sock on, then put a brace on top of it, which doesn't really supply any way to help control compression. Our brace, because it's an elastomer, because we want it to put on nice and snug, and it is snuggable. So that means that we can constantly, change the forces around the ankle, and as that changes, um, the shape changes. From a big fat swollen ankle down to more normal contours. Our brace will adapt to that and will help to control the swelling in the leg. That's really important because swelling is something that persists. It's a really big problem in lower extremity surgery, and all the swelling goes downhill and the foot's at the bottom. So to get that person back into shoes, to get rid of that edema, which can create stiffness, particularly if it stays there, and then all of you as athletic trainers are fighting that swelling, fighting that stiffness that happens from prolonged swelling. We actually can help control that swelling very nicely. Because again, the material and the adjustability of the device.
Gotcha. So with my podcast, I like to talk about a little bit of business in the sports medicine realm. So in the process of putting this brace together from start to finish, what were some of the hiccups, some of the big milestones, as entrepreneurs? What was that process like when you're developing a brace in such a saturated world of bracing?
Yeah, I think the biggest thing was to try to tell people, what is the difference? What problems are we trying to solve with this brace that's not being solved by other braces on the market? And as you said, Shelby, there are literally hundreds, if not thousands, of different types of braces, from just a sleeve to almost a cast-like device. So we how do we differentiate what we did in trying to solve problems that we're seeing in our patient population? I think the main thing is what we talked about. Just kind of there's no brace that fits everybody for every occasion, but we tried to find that happy medium. Okay, how do we get the patients swelling down? How do we get them back into movement, activity more rapidly? What's comfortable for them? What can fit inside of a shoe more readily? And what is modular? So like I said before, that's really seeing the patient through the whole continuum of care, after injury to subacute injury to back to rehabilitation, and then back to normal sport or activities from there. So the challenge that we had was, first of all, the donning and the doffing procedure. We designed the brace with certain structures that would resist the main motions that cause injury, like external rotation or inversion of the ankle at the hindfoot. So that was the design of the brace. We built up the elastomeric body of the brace to try to resist those motions without restricting normal athletic activity, or at least reducing the stiffness of the brace or the feel. And the second thing was the challenge was the donning and doffing, mostly the donning procedure. And again, I can't emphasize that you need somebody who knows what they're doing when they put this brace on, because we've had a lot of people, through mail order or whatever, they put it on improperly. They don't look at the videos. They don't look at the instructions to show the proper sequence for donning this brace. So it doesn't fit properly. It doesn't function the way it was designed to function. So there's a certain process that you have to go through. And here's where the trainers come in. I mean, all the trainers are very well versed on how mechanically things should work. And again, this it's not hard to don, but it's just been surprising to us. And a major reason why some people send the brace back, we get a few returns, certain like 10% returns, it didn't fit. Well, I just wonder if they really didn't put it on properly. So if it is done properly, then it fits properly and it functions properly. So that's where the trainers come in. They can sit with these athletes that have been injured or just want to use it for a prophylactic brace instead of taping, and the trainers are very instrumental. If they know how to put it on properly, they can teach it. They can show the athlete, the patient, how to put it on, and that makes all the difference in the world. I can't tell you how many patients have come into my office and I've showed them how to put it on. They come back with it not done properly, and I show them again and say, "Oh yeah, well now it fits a lot better, and that's how I should put it on," and then they like it. So it is a little bit of a technique, and that's why, just mail order is tough. It's just like, having a patient throw them in a box of tape and say, "Hey, tape your ankle," but so it doesn't work unless you apply it properly. And then the same thing with this brace. And that's why we really hope that the trainers will understand the proper donning procedure and again, show the athlete how it can be used effectively that way.
So part of the challenge was material selection, and elastomers offer, and they're minimally used in bracing. I'm not sure all the reasons why, but they're minimally used. That's a change, and we have a lot of selections and choices as far as the material characteristics. One of the elements in elastomers is called durometer. How hard is it? How soft is it? And when we were going through the prototyping, we actually had 3 different durometers. One was a little, kind of Goldilocks issue. One was way too soft. It was very comfortable, but it just didn't have enough support. The other one was way too hard. It was comfortable, and the one we went with seemed to be just right. So we had to select the durometer hardness. But there's also how much you can stretch it. Again, think rubber band. You have some rubber bands or some balloons that are really hard to blow up and some that are kind of easy to blow up. Same thing with our selection with the material characteristics of the brace. Some are harder to stretch, some are easier to stretch. Some will snap back quickly and some very slowly. So we have options to choose those material characteristics, and we had to go with the general purpose selection in material characteristics. And of course, all that had to be put together with the design so that we provided more global support around the ankle. One of the issues is that we're seeing now how we address ankle instability is different than maybe 15, 20 years ago. The operation that we have used for forever, which is described in the 1960s, was called a Brostrom procedure. Basically, find the 2 ligaments on the outside of the ankle and snug them up. Now it's pretty clear that augmentation is definitely a much better way to go, because many times those ligaments are just too thin and wispy to provide support. There's different materials that are used. And we're also looking again, what's happening on the inner side of the ankle, which had been neglected for a long time. So our brace will support the inside, outside of the ankle and the front of the ankle joint too. In the back, that's hardly ever a problem unless we start talking about syndesmotic type injuries. But it's going through the material characteristics. And of course, you have to go look at the manufacturing. Our brace is injection molded. So we had to have molds made for the different elements of it. And injection molding is not a simple process when you're going through the initial parts of the prototyping side of it. So, but material selection was very, very important because our brace uses biomimetic principles. And biomimetic just means that how does our body work? What has nature taught us through, millions of years of evolution? And what we do know is that tendons will stretch a bit and then rebound back. Same thing with muscles, and ligaments actually will do as well. So instead of forcing the ankle into a rigid type of device that may or may not work with it, we're using biomimetic principles on our brace. In addition to that, everybody's used to working with bands as far as exercise. I mean, that's just normal. Our brace functions as a band. So if you're walking, running, using it, you're going to push against resistance. So as you push against resistance, you're going to work those muscles, lots of little bits. Those 10,000 steps that you get in, well, you're pushing against resistance every time you're wearing the brace. Another real key element too on the brace material and the brace design is proprioception or position awareness. Why do people with chronic ankle instability get in trouble? They don't know where their foot is. They land and I didn't know my foot was turned under. Well, we're not going to insulate you so much. The brace is a little tacky and it's going to pull a little bit. That's important. It's not so thick and it's not so rigid that you're insulated from the ground. All those things go into really a better experience for people who are actually going to use it. If you're just going to stand, you're not really going to see it come to life, so to speak. So again, the material choice was actually a bit complicated because it also had to be biocompatible. That was another part of it. We didn't want to put a brace on, everybody's getting a bad skin reaction to it. So we had to, fall within a class of biocompatibility. Probably the least thing was the color. We can make these in any color you want, but we kind of went with a pretty blasé sort of black and gray. But yeah, they can be in any color.
Yeah. So you talked about like the skin reaction. Do you recommend if people wear socks under it or go skin to brace?
So you don't need to, we really haven't seen any skin reactions with it. I think a thin sock is probably a good idea just because it's a little bit more comfortable with a thin sock as the underlayer and will help to absorb some of the sweat and wick away some of the sweat. Yeah, a sock just makes it a little bit more comfortable. It shouldn't be a really super thick sock, but a thin sock will work just fine.
Yeah. Well, and talking about the education of the product, I mean, for how many years I've been working, just talking about cam boots and trying to get the athlete to put it on correctly when they go home, I just, I don't know what it is about medical equipment and making it user friendly. And I mean, I've used your guys' product. Yes, you need like one information session, but after that, I feel that it is pretty easy afterwards. Cam boots are just a different story. I don't know why they're so hard to replicate and putting on when people go home, but I would definitely vouch that the education is always the biggest portion of a newer product and trying to change the system. Everybody's used to probably lace up or the rigid ones where you just Velcro it around. There's no real finesse to it to make sure it adequately fits. So it was great to hear about that. And, athletic trainers, I think, could be a pivotal point in educating the masses on how this is used and it becomes a normal piece of equipment at the end of the day.
And I think it's important for trainers to know that there's no brace in the market that fits everybody for every occasion. Some ankles are really thick and short, and some are skinny and long. And this brace doesn't fit everybody, but it probably fits 90% of the patients that we put them on, as long as they're donned properly. And even with the brace, I mean, we could really stiffen, as David said, the durometer of the elastomeric to make it even stiffer, but then it will compromise performance if we do that. So we try to find that happy medium where people can still feel enough support to reduce the risk of injury, but it doesn't eliminate the risk of injury. Only a cast would do that. I mean, and people won't perform in a cast. So it's always a trade-off, and it's you want support, but you don't want restriction of movement to the point where they can't perform at the level that they want to perform. And it's not just athletes on a field or a court. We take care of a lot of industrial athletes, people who are on their feet all day, working in manufacturing or like UPS, FedEx. I mean, these guys and gals are really athletes. They're jumping in and out of trucks, and they want a certain amount of support. I mean, they don't want to resist, like I said, the strain of the muscles, as David was talking about, because you still want your muscles to have some strain, some tension on them, but yet something that does give support, an proprioceptive sense of where the foot is in space, and still allow them to do their jobs or perform on the field or the court.
And also in design, the top ankle strap is a really important. It's an anchor point for the figure eight strapping as well as just for the elastomeric boot. You have to attach to something stable. We looked at two straps versus one strap. Two straps, which is what we settled on. It's a little finickier to do the initial threading through, but the trouble with the one strap was when people would tighten it, they would just rotate the top part. And then the brace was it wasn't fitting right
Yeah,
anymore.
the boot
And
the boot
so it
was
was
rotated,
simpler.
so it wasn't fitting. Yeah.
Yeah. So that's why we went with the two straps, because now it's going to fit right. It provides a critical anchor point. The shoe helps to hold the brace below, but the top strap is very important. If you look at other types of braces, you'll see that they don't have much of a top strap. So if you're anchoring, um, other straps to it, then the problem is that you're not anchoring it to anything solid, and it's going to pull it down. It's going to twist it, versus where we are, which is very, very stable. Um, Very important. So that's another element on the design side. And we spent quite a bit of time just going back and forth. What do we do for the top? We know it's important. It's called a supramolar suspension. Uh, but how do we make sure that it doesn't cause other problems?
And another thought about that top strap, David, is in what we found in practice as well. A lot of these ankle sprains are external rotation injuries. Plant and pivot, and then the foot rotates out as the foot is stuck on the turf or on the court, and the body rotates internally and causes tearing of the deltoid and syndesmotic ligaments as well. So the top band, and there's been a report from University of Iowa, Ned Amendola, the current president of the academy, did a study along with Bryan. They're both sports doctors at Iowa, and they did a taping test. And this is really kind of a neat thing for trainers to do as well. They would put a couple bands, or 3 or 4 turns with the tape around the supramolar area above the ankle, and that would squeeze the syndesmosis together. And so if the patient could walk more comfortably, that would, because that tape reinforces the position of the fibula and takes the strain away from the injured ligaments. It was a diagnostic test to say, okay, this patient actually has his or her pain's coming from the syndesmosis and not maybe the lateral ligaments or the deltoid ligament. So again, this is that top strap. If you tighten it tight enough, it will help in those minor syndesmotic injuries that allow the patient to get back, give them the support, and get back into practice more rapidly. So I found that can also not be just for lateral instability or just an anchor point for the two main figure eight straps. It can also be therapeutic, and it can squeeze the fibula into the incisura, which is the divot inside the lateral tibia where it normally sits, and it helps pull that into that bony structure so that it takes less strain on the ligaments. So that's kind of an after benefit that we didn't really necessarily plan for, but it really does make a difference.
Yeah. So I think we've captured a really good picture of this ankle brace. Was there anything else that we missed that you guys wanted to talk about the brace, or just ankle injuries in general, to get out to the population of athletic trainers to look for when they're evaluating ankle injuries or putting together prevention programs? Any tidbits that you guys want to get out there?
Ankle injuries are undergoing just so much more intense study. There are medial only or deltoid only types of injuries combined with posterior tibial tendon injuries or flat foot injuries. Our brace works really well for not a severe deformity, but for that mild, moderate deformity or medial type injury too. Prior partner hurt himself playing basketball, tried a bunch of braces, put ours on, and said, I can now cut and play basketball again. And this is a medial injury, not that typical classic lateral injury. I think probably one of the biggest things is as an athletic trainer, and we hear the same thing from physical therapists, the line is, we got to get you out of that brace as soon as possible because it's going to make you weak. We hear that all the time. And, there's an element to that because, again, you're insulated. You can't really feel the ground. It's just tight. It's just not comfortable. People just don't want to wear it, whether you're in athletics or whether, again, you're that industrial athlete or you're just, somebody who just has had an ankle injury. So we have a device that actually works with what you want to do with them on the rehab side and the prevention side. You're teaching them proprioceptive exercises. You're teaching them lower leg strengthening. Last thing you want to do is put them in a device that does exactly what you don't want them to do, whether it's after injury or to prevent an injury. So we actually, we have a device that works with current treatment. I think that's maybe the biggest take home.
I'd like to add two things, Shelby. I think one is, as David was mentioning, there, a lot of ankle injuries, and trainers, I'm sure, are seeing this as well. And we did in orthopedic foot and ankle patients, is that it's not just a lateral ankle sprain in most cases. I mean, there's, in fact, studies show out of Duke, they've showed that half of the lateral ankle sprains also have a deltoid injury. Half of the ankle sprains, when they MRI scanned them, they were tender on that side, but the patients were only treated for lateral ligament instability. And again, canvas braces, I mean, they're stiff. They may support both, but again, that slows down the patient rehab. And so I would like to make a comparison to the knee reaction brace. Don Joy came out with that several years ago, but it's an elastomeric brace around the knee. And you first put it on, you say, well, there's no stirrups, there's no stays on either side of the knee, and because it needs to be rigid and needs to be supportive. But amazingly, patients, put the knee reaction brace on and said, well, yeah, this is good, both medial and lateral support and also anterior posterior. So, and that's the same way because of some material difference between just plain braces or straps or whatever. And so that elastomeric is very, the ankle that we use in our Vero ankle brace is very analogous to the knee reaction brace, and as far as controlling multiple directions of instability. So I think it's, I'm trying to think of the second thing I was going to tell you. But so if you take the brace out of the bag as a trainer and say, okay, I'm going to put it on myself to try it, first don it properly, okay? And then put it inside of a shoe, and a little bit wider shoe to get it in if you use the stirrups properly. But then people say, well, it doesn't feel that supportive. Well, then get on the court or get on the field and start cutting with it and moving with it. And that's when people see the difference. And same thing with a knee reaction brace. You don't really feel the benefit until you start to go through your normal movements, whether at work or on the field or the court. So try it on and move with it. Don't make a judgment just by saying, well, it doesn't feel supportive. It doesn't, and Canvas will do that. If you put it on, it'll feel immediately more rigid than what you had, but it doesn't give with your body motions. It doesn't protect all ranges of motions of instability. So those are the two things I wanted to share with you.
Yeah. Have you guys done any formal research on your brace? And if athletic trainer or an athletic training student was interested in doing research, are you guys open to working with them on creating research?
Yeah, it's really hard to do a prospective follow-up because it's hard to get patients to respond to, patient-reported outcome, surveys and so forth. I do a lot of research still with Twin Cities Orthopedics, and the biggest challenge is getting patients to send back the surveys 2 years out from surgery, 4 years out from surgery, and honestly, our follow-up for these kind of patients would be shorter, but I think a trainer would be uniquely positioned. They have relationship with these people. They can follow up. They have continuity with them. And so they would be ideally positioned to do that kind of research. But we have had a lot of anecdotal follow-up and patients calling, and I've seen them in my practice for 4 years using this brace. And Again, the feedback has been mostly good. Again, I think we mentioned previously in the podcast some of the challenges that we've had. Some ankles they just don't fit well on, but that's true of any brace. They have odd-shaped or really thick ankles that they can't get into a shoe with the brace on. So I think there's outliers, but I would say 90% of the patients really enjoy the compression and the stability and the modularity of the brace. They can take the stirrup, the one or both of the stirrups out anytime in their rehab process when they think they don't need them anymore. So I think, that's the advantage.
So yes, we clearly would be open to any trainer wanting to look to do a study. I think we can provide a lot of input. One of the key elements is, do people have a confidence in the brace or not have a confidence in the brace? Do they feel that impedes their performance? Yes or no? I think that's probably one of the biggest questions, which is one of the big pushbacks for a lot of the braces, especially if you look at certain types of players, the skilled players in football, the receivers, the safeties, they don't want to be restricted at all. Basketball players don't like being restricted because it cuts down on their ability to cut and to turn. Same thing with tennis players. If they're too restricted, then it's a problem for them. They don't have confidence in it. And the go-to, this is again part of their initial discussion, looking at from Ned Amendola, who's now at Duke, said, the players, we give them a more stiffer brace. They take them off and they put a compression sock on, which doesn't do anything. Just kind of keeps their ankle warm. Or if they've had, they've had an injury and they have some swelling, it might give them something, but it doesn't really do much of anything for them. So it's finding that device that will do what everybody wants, which is the user and the ones making the recommendations for the use. So yes, we would be open. I think we can provide a lot of insight as far as guidance, as far as setting up a study. Yeah,
team trainers would be uniquely positioned to do those kind of follow-ups for us.
Yeah, definitely. So you guys have a website, www.veroankle.com. If anybody wants to look up more information, definitely reach out if you listen to the podcast and let the company know that you've learned and want to get involved, or you're interested in utilizing this in your clinical care. Any last notes from you two on wrapping up, and any last tidbits?
Thanks, Shelby, first of all, for the podcast. And if anybody has any questions, as you said, the Vero Ankle website will answer a lot of questions for you. But again, we'd be happy to answer questions by a phone or somewhere, email, etc.
Yeah, thank you.
Yeah, thank you so much, guys. We'll have you on in the future.
Thank you.
Thanks.
That's it for today's episode of To the Bone. I hope we've sparked some new thoughts, challenged your perspectives, or simply reminded you to dig a little deeper. Remember, life isn't just about what's on the surface. Sometimes you've got to cut deeper and get to the bone of what really matters. To the Bone podcast is a product of Daily LLC. It's hosted and produced by Shelby Daly, ATC, and Randy Daly. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. For more on the show, visit www.tothebonepodcast.com. If you enjoyed this episode, be sure to subscribe, rate, and leave a review. Get involved in the conversation. You can find us at www.tothebonepodcast.com. Drop us topic suggestions or be a potential guest. We're all about connecting with you, our listeners. Until next time, stay curious, stay grounded, and keep cutting deep.